Today we will discuss acute liver failure. This is a clinical scenario about acute liver failure. You can study it, and as usual, please write down your answers on your books, and we will try to find the answer in between the lecture, and maybe we will discuss at the end. This is the second scenario. You can pause and you can read it, you can understand it. So what is acute liver failure? Acute liver failure is an hepatocellular dysfunction, rapid deterioration of liver function which result in coagulopathy, that is INR more than 1.5, and encephalopathy, that is alteration in the mental status to a previous healthy individual. So acute liver failure may be fulminant or subfulminant. It has got two subtypes it means. Fulminant hepatic failure is characterized by the development of hepatic encephalopathy within 8 weeks after the onset of acute liver disease. Coagulopathy, that is mentioned by INR more than 1.5, is invariably present. So this is the hallmark for the hepatic failure. Subfulminant hepatic failure occur within these findings appear between 8 weeks and 6 months after the onset of acute liver disease and carries an equal poor prognosis. It means fulminant hepatic failure within 8 weeks and subfulminant hepatic failure 8 weeks to 6 months. These are the causes of acute liver failure include drugs, toxins, vascular phenomena like ischemic hepatitis, CHIARI, metabolic like Wilson's, pregnancy such as acute fatty liver, eclampsia, HELP syndrome, miscellaneous causes, and indeterminate or unknown causes. So viral hepatitis is one of the causes. Hepatitis A and B account for most of these causes. Hepatitis C rarely causes acute liver failure. Hepatitis D as a co-infection or super-infection with hepatitis B can lead to acute liver failure. Hepatitis E, often observed in pregnant women in an endemic area, is an important cause of acute liver failure, and we live in an endemic area and we see Hep E in pregnant female quite often. Atypical causes of viral hepatitis and acute liver failure include herpes simplex virus, cytomegalovirus, Epstein-Barr virus, hemorrhagic fevers viruses, and paramyxoviruses. Acetaminophen hepatotoxicity is a famous cause of acute liver failure. It is dose-related toxin, most ingested leading to ALF exceed 10 gram per day, that is 150 milligram per kilogram. However, severe liver injury can occur rarely when doses are low, as 3 to 4 gram per day are taken. Very high ALT levels are typically seen, and serum level exceeding 3,500 international unit per liter are highly correlated with acetaminophen poisoning. Drug-induced liver injury. Drugs other than acetaminophen rarely cause dose-related toxicity. Most examples of idiosyncratic drug hepatotoxicity occur within the first 6 months after drug ingestion, and classes of drugs commonly implicated include antibiotics, NSAIDs, and anticonvulsants. Certain herbal preparations, weight loss agents, and other nutritional supplements have been found to cause liver injuries, so inquiry about such substances should be included in the complete medication history. Wilson disease is an important cause of ALF, though it is uncommon. Typically occur in young patients, accompanied by the abrupt onset of Coombs negative hemolytic anemia with serum bilirubin level more than 20 mg per deciliter. KF rings are present in about 50% of the patients. Serum ceruloplasmin is typically low but may be normal in up to 15% of the cases and is reduced in 50% of other forms of ALL. High urinary plasma copper levels as well as hepatic copper measurements will confirm the diagnosis. Very low serum alkaline phosphatase and uric acid levels, a high bilirubin to alkaline phosphatase ratio more than 2 is a rapid indicator. Chiari syndrome is the second cause. This is called hepatic venous thrombosis. Abdominal pain, ascites, striking hepatomegaly are often present. Diagnosis is confirmed with hepatic imaging studies, computed tomography, Doppler scintigraphy, MRV, and testing to identify hypercoagulable conditions like polycythemia or malignancies. Acute ischemic injury like shock liver, in cardiac arrest, significant hypotension, hypovolemia, severe congestive heart failure, drug-induced hypertension, hypoperfusion, long-acting niacin, cocaine, methamphetamines, documented hypertension not always found, transaminases often more than 1000 to 2000 milligram per deciliter, simultaneous renal insufficiency and a muscle necrosis often found. Autoimmune hepatitis patients that develop ALF represent the most severe form of the disease. Autoantibodies present up to 30% of the cases. Liver biopsy should be considered in if autoimmune hepatitis is suspected and autoantibodies are negative. In pregnancy, acute fatty liver of pregnancy, HELP syndrome, that is abbreviation of hemolysis, elevated liver enzymes, and low platelets. A small number of women near the end of the pregnancy will develop rapidly progressive hepatocyte failure associated with increased fetal or maternal mortality. A variety of presentation may be seen generally confined to the last trimester. Triad of jaundice, coagulopathy, and low platelets are present. Hypoglycemia and features of preeclampsia are common. Malignant infiltration of the liver may cause acute liver failure. Acute severe hepatic infiltration occurs with breast carcinoma, small cell lung carcinoma, lymphoma, melanoma, and myeloma. In patients with ALF who have a previous cancer history of massive hepatomegaly, consider analyze malignancy and obtain imaging and liver biopsy to confirm or exclude the diagnosis. Clinical manifestations. Many of the clinical symptoms in patients with acute liver failure are non-specific like fatigue, malaise, anorexia, nausea, vomiting, abdominal pain, and lethargy. As the liver failure progresses, patients who were initially anicteric may develop jaundice, and those with subtle mental status changes like lethargy, difficulty in sleeping, may become confused or eventually comatose. The presence of hepatic encephalopathy is one of the defining characters of acute liver failure, and these are the grades of hepatic encephalopathy. You must remember the grades 1, 2, 3, and 4. This is an important viable question as well to grade the encephalopathy of the patient, the hepatic encephalopathy in particular. The complications include CNS disturbances, as we mentioned, hepatic encephalopathy, cerebral edema and seizures, infections, coagulopathy and bleeding, renal failure and hemolytic collapses, and metabolic derangements. Differential diagnoses include acute decompensation of cirrhosis, alcoholic hepatitis with underlying cirrhosis, sepsis with multiple organ failure syndromes, eclampsia and preeclampsia, severe liver involvement of systemic infections, malaria, typhoid, leptospirosis, rickettsial infection, etc. History, physical examination, and investigations are required to diagnose acute liver failure. History included of an onset of jaundice and encephalopathy, of course, to classify further into fulminant and subfulminant failure. Alcohol abuse, medication use like prescription or maybe recreational, herbal or traditional medication use, family history of liver disease like Wilson's, exposure to hepatotoxins like mushrooms and organic solvents, exposure to risk factors for viral hepatitis, that is the travel, transfusion, sexual contacts of patient, body piercing, evidence of complications like renal failure, seizures, bleeding, infections. And physical examination include mental state examination that are grading the patient in hepatic encephalopathy, searching of the stigmata of chronic liver disease, usually it is absent, jaundice, right upper quadrant tenderness, which we call as tender liver, hepatomegaly, which show viral hepatitis, malignant infiltration, congestive heart failure, but CHIARI syndrome. Physical examination also include rapid development of ascites in acute liver failure patient, accompanied by abdominal pain, suggests the possibility of Budd-Chiari syndrome. Clinical signs of elevated intracranial pressure, the systemic hypertension with bradycardia and irregular respiration, causing triad of other neurological changes such as pupillary dilatation or decerebrate posturing. Initial investigations are shown include CBC, LFTs, RBCs, electrolytes, renal function test, blood group screen, pregnancy test may be in an appropriate gender and age group, ABGs, ammonia levels, and arterial lactates. Viral hepatitis profile, Wilson disease, autoimmune hepatitis testing, Budd-Chiari syndrome, drugs and toxin screen, and indeterminate cause is proven by liver biopsy. Management include therapy of acute liver failure consists of general supportive measures like complication specific therapies for the sum of the etiology, liver transplantation, and other methods of temporary liver support. Treatment of complications are these are tabulated intensive care of acute liver failure, how we treat hepatic encephalopathy in 1 and 2 grade and 3 and 4 grade, how we treat infections, coagulopathy, hemodynamic or renal failure, or metabolic concerns. Specific treatments include etiology like viral acetaminophen, drug-induced liver injury, mushroom poisoning, and pregnancy. Autoimmune hepatitis, ischemic injury, hepatic vein thrombosis, Wilson disease, malignancies. All the treatments have been summarized and you can read it, you can have a notes, and you can briefly prepare your own things. Liver transplantation remains the only effective therapy for acute liver failure in the patients who fail to recover spontaneously. King's College criteria is used to select the patient that should be referred to a transplant center for transplantation. These are the King College criteria for the selection for the patients who need liver transplant in acute liver failure. Liver support systems are support devices which develop in arresting the liver to provide it sometimes to recover. There are two kinds of devices, sorbent-based artificial system and cell-based bioartificial system. There is no good evidence showing a decrease in mortality with their use in acute liver failure, and they are not currently recommended outside of the clinical trials. Prognosis of acute liver failure is most significant predictor for the outcome. Acetaminophen hepatitis A shock liver pregnancy related with more than 50% or LT-free survival. All other less than 20% of LT-free survival. Degree of encephalopathy grade 1 to 2 with 65 to 70% spontaneous recovery, and grade 3 to grade 4 less than 20% only. Age is an important indication. More than 40% or less year or less than 10 years have worse outcome, means in the end of the ages. So this was the scenario we discussed in the start of the lecture. This is the explanation. These are the signs of hepatic encephalopathy point towards liver failure. rather than just severe hepatitis. Rest of the features include coagulopathy could come in both. This was the second scenario, and the answer is this. Answer you must have seen in the lecture how you diagnose and how you investigate it. So to summarize the things, patient with ALF should be hospitalized and monitored frequently, preferably in an ICU. The precise etiology of ALF should be sought to guide further management decisions. NSE may be used in setting of non-acetaminophen ALF include DILI and hepatitis B, that is drug-induced liver injury. The development of cerebral edema is the major cause of morbidity and mortality in patients with acute liver failure. Thank you very much.